sorry about that. There was a disturbance on my phone. Yes, we are going to have the BLN AeHIN joint panel discussion on MOH response to COVID-19. We have, I believe, 4 panelists, and I'll just ask them each to introduce themselves. 2 are from Asia and 2 are from Africa. Can I ask Dr. Fazila to introduce herself?
Hi, hello everyone. My name is Fazila. I'm from Ministry of Health Malaysia. I'm the Senior Deputy Director in the Planning Division of Ministry of Health Malaysia. And I'm very much involved in digital health and innovation and also looking to strategies of digital transformation for Ministry of Health. But during the COVID, I was mainly involved in the areas of quality and patient safety, and also mortality review for the CPRC, which is our Crisis Response Center. So I really hope I can share a lot with you today, along with the other panelists. That's all. Thank you.
Thank you so much, Dr. Fazila. Can I ask Enrique? What's his name? Yeah, Dr. Enrique Kayad.
Yeah, thank you so much for the invitation for this joint webinar with the Better Immunization Data Learning Network and the Asia eHealth Information Network. It's a privilege to join the other panelists this afternoon. I'm with the Department of Health. I'm Dr. Enrique Taya. My nickname is Eric for short. I'm with the Knowledge Management Information Technology Service. I'm an epidemiologist, infectious disease specialist, and then now I'm the director of the office that provides ICT support to the Department of Health and the health sector as well. And for this COVID-19 pandemic response, I'm responsible for many things like the health information systems, ICT tools and applications that's needed. And I'm a member of an interagency committee or group that has the task to have an oversight for all these things. Thank you, and I hope to share our lessons to this afternoon.
Thank you so much, Dr. Tayand. Can I ask Calvin Tonga from Cameroon to introduce himself?
Hello, good morning. I'm Dr. Calvin Tonga, working with the Central Technical Group for the expanded program on immunization in Cameroon. I'm the officer in charge of planning, monitoring, and evaluation. And I'm very happy to be part of the discussion panel for today. Thanks.
Thank you so much, Calvin. Can I finally have Mr. Amos Kidai Kiteleja from Tanzania?
Yeah, thank you. I'm Amos Kitereja from Tanzania. I'm working in Mwanza region. So I'm a health officer working as a regional immunization and vaccine officer in the Mwanza region. During COVID-19 pandemic, I worked as a surveillance officer in the Mwanza region, coordinating all surveillance activities. So I'm very happy to be with you. I think I will share some important things with you, and then I can get something from you. Then I will do something much better then. Thank you.
Thank you so much for that introduction. Welcome to the panel. The format we're going to have is I'm going to pose a question to the panelists, and once they respond to my question, I'll just allow 2 or so minutes for the audience to also pose their specific questions on that specific aspect of the discussion. So my first question to the panelists is, what challenges are being faced by the country health sector as a result of the COVID-19 pandemic? We are particularly interested in the challenges in terms of how you're going to manage the delivery of health care services in spite of the diversion that is posed by COVID. Can I have Dr. Tayag setting us off? Dr. Tayag, I think you're muted. You're just talking to
I'm
yourself.
sorry. Excited. Okay. Thank you for the question. The challenges as we face the COVID-19 pandemic and our response to it revolves around the access to health services because there has been a disruption, and every person or individual that thinks if they have the symptoms or not, they want to verify them. And so there are restrictions to travel. Right now, we have different modes of quarantine that are being imposed in different areas in the country. We have 224,000 cases, for example, and over 3,000 deaths. And so the challenge is how to keep this number from rising more than what we have estimated based on our applications of tools, digital tools, so that it can support our response. So another challenge is the coordination of the different players that are responsible for making sure that the response is actually effective and coordinated. Another challenge is actually how to always remind people that responsibility starts with them, that staying home, wearing masks, hand washing, physical distancing remain the important non-pharmaceutical measures. And of course, we are challenged by sometimes with our health system capacity, especially the hospitals if they are overburdened. And we worry about our frontliners, those in the hospitals and those that make sure that quarantine and isolation of patients or cases actually take place. There are so many challenges. We have to actually prioritize them. So our first response was to organize ourselves so that there is an interagency task force, Chilunga, and I want to share this with the panel that actually make decisions based on information that we get immediately. Maybe I'll end with that. Thank you.
Dr. Fazila?
Yeah, I mean, we too had many challenges. I will just add to what Eric has mentioned, other than access, capacity, healthcare workers. I think the other big challenge, which I think many countries would have, will be this lack of like a single data source and also analytics. I think that is very important in pandemics. And also with the rapidly expanding knowledge and new scientific data that is coming out like in a very rapid manner, that has made this whole pandemic is a huge challenge to manage. Of course, as mentioned earlier, we have healthcare workers, issues of mobilization of healthcare workers to where it's needed. Mental well-being is also another important aspect, especially with lockdowns. We can see increase in depression, anxiety, abuse, which is also being demonstrated. But as you know, the pandemic is not only a public health crisis. It is also an economic crisis, a social crisis. So there are many other challenges that comes about. For example, unemployment, economic contraction. Fake news management is another huge challenge we are having, especially with social media. But somehow we are able to handle that. Yes, we have all the service disruption, especially when we make some of our hospital as a full COVID hospital. We have to move other services out of the hospital. And also fear and social disruption is another challenge as a society. Another one that I would think that has really had a major impact is the supply chain disruption. In the initial period, we had so much issues in getting, buying more ventilators, getting PPEs, even as simple as face masks, and also reagents, lab reagents. Basically, I think these are some of the issues on top of what Dr. Tayak has mentioned earlier. Yeah.
Thank you, Dr. Fazila. Can we cross over to Amos Kiteleja, Tanzania?
Yeah, thank you very much. Of course, in Mwanza region here in Tanzania, the many challenges that we face, one of them was the number of staff who are qualified to practice in COVID in case management. Though the ministry or the government has tried trained a number of staff, including physicians, nurses, and the other persons to manage cases, though this was a great challenge for the staff who are knowledgeable and capable to manage these cases, though training seminars and the workshops were conducted to make sure that staff are well understood on how to manage these cases. Also the space, this is because the space that we have, that is hospitals, health centers, or dispensaries. So we expected maybe there will be a greater number of cases. So where can we put this for case management? So this was another issue or a big challenge to us, though the number of cases that we expected were very little, so that we are very lucky. So we managed to treat cases that we have in our region. Also, another challenge was due to supply chain, that is supplies availability. It was another great challenge to us, but some private sectors, donors, intelligence organizations helped us to get some supplies. So we are very lucky to get these things. So a great challenge was the number of staff, was space, and some supplies to manage cases in our areas. So that were challenges in our areas.
Thank you so much for that update from Tanzania. And finally, Calvin Tonga from Cameroon. Can you give us your challenges?
Okay, thank you, and thanks to the other panelists for their country experience. In Cameroon, I will mostly talk from the point of view of immunization. We were faced with different challenges depending on the health pyramid level. So at operational level, there was a challenge in service delivery because immunization sessions have much of socializing, health information, and also contact with children and parents. And with COVID, there was social distanciation and use of personal protection equipment. So this has been a challenge as we needed to mobilize all this equipment and also change the way things were being done at the operational level during vaccination sessions, not gathering parents and children, respecting the distance between two persons. So that was one of the challenges at the operational level. The other challenge was also the fact that some of the vaccination is part of the minimum package in most of the health facilities, and they are implemented alongside other health activities as consultations. And you see COVID patients were received in health facilities, and in these same health facilities, vaccination activities were offered, and parents were like reluctant to go to the hospital for vaccination. because they were afraid they might be contaminated by other people who were there for COVID. So this caused a reduction in the demand side of the activity. Added to that, we also had rumors, mostly on social medias, on vaccination against COVID. That also made parents more afraid of going to her facility for demanding immunization services. Now at management level, that is central level, we were challenged with issues concerning logistics because of ban on flight, and most of our vaccines are supplied by through flight, cargo flights. So the initial planning that we made with all suppliers could not be respected due to all the constraints because of COVID. And we had to work with our partners to redesign the system in order to have the needed vaccines. And this resulted in a stock out of some very important vaccines, including the GPT containing vaccine in our system. And the other thing was also in this emergency situation, to come up with guidelines that will help people at the various levels so that they could maintain the continuity of immunization activities, although COVID was there with a number of restrictions in the system. So overall, the main impact we could have in the system was a drop in the vaccination coverage that we observe across the country, mostly in her facility that usually contribute in vaccinating most of the children, and also the stock out of vaccines that we also experience. And all meetings or training or seminars were stopped following the regulations that were set by the Prime Minister in order to control the spread of the COVID. So this is what happened in Cameroon and the challenges we were faced with. Thank you.
Thank you so much to all the panelists. That is really it really has been very, very challenging from what we can hear. There is a question from Alvin Marcelo, who's saying COVID challenge had stretched the capabilities of all governments around the world. How did you manage the offers of support from the private sector stakeholders? In this complexity of challenges, how did we manage the support from private sector stakeholders? Anybody on the panel can answer that from Alvin Marcelo?
Can I take that question?
Please do.
Yeah, you know, we had so much. I mean, the support was amazing. In fact, it was we were overwhelmed in the beginning. You know, there was support from the private sector, from the academia, from NGOs, even from civil society and public at large. But a lot of coordination, I think, for this COVID, we did centrally. At the national level, there is a central coordination committee that is led by the National Security Council. So there are also a lot of other agencies who have private sectors coming in to offer the help. The help can be in many areas, you know, in terms of donations, PPE, food, logistics. There's also help in terms of counseling and so forth. But at the ministry level, we also have the crisis center where we coordinate everything for nationwide. So for donation, it is coordinated centrally, and each state also have their crisis center. So we try to avoid people going direct to the hospital because they are already overburdened with the condition. So this is how very tight coordination needs to be done. But I think when I look back, I think better coordination can be further done, especially when, in terms of donation. So that's how it's done. And many private sector also offered CSR, corporate social responsibility, for example, in a developing app or system and so forth. So that was very helpful in this pandemic.
Fantastic.
Thank you.
We have did you want to say something, Dr. Tayang?
Yes, because the private sector has working with them has been amazing. Maybe because of the relationships we have built with them over the years. It ranges from, for example, supporting us with our telemedicine project, and as Vasila said, augmenting the supplies for our PPEs at the very start, helping with our laboratory testing capacity, putting the word out there so that we're not overwhelmed by fake news. So the private sector have been so helpful, and they have supported us for our digital needs, for our IT solutions. And in fact, without them, the success that we have in making sure that our COVID-19 outbreaks do not go out of control. And we have to thank them really. It has been a tremendous effort for them, and we're so thankful.
Yeah, I agree. It was just
Great.
amazing. Yeah.
Thank you. Any contributions from the African continent on this particular issue? Private sector?
From Cameroon.
Yes.
The government had opened a fund for those who could contribute in fighting COVID. And we saw the private sector has been very dynamic in contributing into this fund. And many companies, both local and international companies, contributed. And this there were not only financial contribution, we also got material contribution, mostly the equipment, resurrection equipment needed for COVID severe patients. The personal protection equipment also were offered, and some donation went directly to main COVID management centers, central hospitals in the 2 capital cities in the country, precisely Douala and Yaoundé, where many companies went directly to offer their donation, both in nature and in kind and financial. Coming back to immunization, we have been facing challenges also in having personal protection equipment for the personnel at the front line. And as part of their activity, the Emergency Operational Center for COVID has been advocating with private companies for supporting the fight against COVID. And just of recent, the company offered to provide for personal protection equipment that will be directed towards personnel that are involved in immunization activities. Right now, we are working with the Emergency Operation Centers for COVID to organize this donation so that the personnel, the frontline personnel in charge of immunization, should have more of this equipment and continue their service while remaining safe from COVID. Thanks.
Any other comments from Tanzania?
Yeah, thank you very much. Even in Tanzania, private sectors, we were working together. Even supplies we get from them. Private sectors, especially for hospitals, for example, they provided us some PPEs, personal protection equipments. Funds also, although funds were centrally managed at the ministerial, at the national level. So at regional level, we were not supplied with funds only. Only we get materials, including sanitation facilities, for example, sanitizers. Also, in terms of immunization services, because staff who were managing these cases also were were staff from health facilities who were conducting immunization services. So all facilities, for extra PPEs, were directly supported to that facilities. So masks and the other equipments were directly sent to health facilities. So private sectors contributed a lot in our areas to combat this disease, that is a COVID-19 pandemic. So there was a good contribution from private sectors. Thank you.
Thank you very, very much. Now, I understand that Dr. Aaron Mjajati has joined. Is that correct, Aaron?
Yes, it is, and okay. I didn't want to interrupt, so I suggest that you continue, and I'll just listen in.
Are you sure?
Yes, I'm very sure. You are doing a good job so far. If I have a question, I'll ask, but so far you're doing a good job of moderating. Let me not interrupt the flow of the discussion. I think you're doing a good job.
All right.
So far.
Okay, Dr. Mjajati. Thank you.
All right.
Okay, fine. Now we've heard a lot of challenges, both from Asia and from Africa. We've also heard the positive response of the private sector. And I just want to ask the panelists, are there strategies and lessons that you've learned as a result of this pandemic that you can share with us? Those strategies that maybe for now and for the future will be able to help us in the way we implement health service delivery. You know, because, well, I know we wouldn't want to say, but I'm sure the COVID-19 won't be the last pandemic. So what are those things we've learned in terms of maybe supply chain management, service delivery, demand creation, human resources, PPEs? What are those strategies and lessons that we can beneficially share with each other that will help us to improve the way we are doing things now and the way we'll do things in the future?
Thank you, Chilunga. This is Dr. Tayag again. For the Philippines, for example, we had to introduce telemedicine. In fact, I was responsible for establishing a COVID-19 hotline so that individuals can actually get information from this hotline. And it easily became a telemedicine platform. And we had to work with other private partners so that other models of telemedicine were introduced. Right now, we have introduced telemedicine in local governments, and we plan to scale this up. What happens with telemedicine is that it allowed individuals, maybe they were scared, maybe there were restrictions for them to visit health facilities. And so therefore, we had to reach out for telemedicine providers. We got doctor volunteers. So once we had set it up, we had to receive so many calls, and it was available 24/7. And so these calls use an algorithm so that it became a triage, so that the quarantine isolation services were available to them through this telephony or telemedicine. And now we have introduced virtual telemedicine. Thank you, Chilunga.
Thank you so much, Enrique. Can any other panelists add on to that, please? Dr. Fazila?
Yes, we too experience the same digital transformation. It just occurred like, in such a speed manner with this pandemic, telemedicine, virtual clinics, and many other things. But I think what is also important is moving forward, I think analytics, data analytics is very important, and we need to become, every organization or health sector needs to become an insight-driven kind of organization, especially with the speed and this pandemic is happening and the data, new data that is emerging. I think that will be another important thing. And I think also we must also strengthen our local manufacturing landscape. We were so dependent on PPE and reagents and all as an import. And during this pandemic, I think it was really a bitter lesson when we did not have enough of all this. In fact, the 3D manufacturing, 3D printing, suddenly it flourished, and everyone was doing 3D printing to help the Ministry of Health in PPE. So I think the local manufacturing capacity must be looked at in moving forward post-pandemic.
Excellent. Calvin Tonga?
Yes, thank you. In addition to what has already been said, I think we have some key lessons that were learned and that we have started trying like to capitalize. First is the contribution of local government to activities. In fact, in our country, we have better city councils. And these city councils were very instrumental in the peak phase of the COVID, in mobilizing additional human resources in the community for sensitizing against COVID, and also encouraging people to go for testing. So we discovered that this this city council could be of a great help in our immunization activities. For example, providing for community health workers or supporting community health workers. We engage with health teams in making sure that all members or all targets in the communities are being immunized, and we've started working on that. Second is the contribution of the private sector. For a long while, we've not been able to develop an approach on how to collaborate with private companies in supporting some very important health activities. But with this COVID, we've tried something, and we've seen that there is a potential for these companies to directly contribute in supporting her activities when there is critical need for resources. And this we are also working on. And the last aspect of it is preparedness for emergency situation. COVID has affected our supply chain. It has also affected the way service delivery is being performed at her facility level. So we came up with a guideline on how to maintain immunization activities during the outbreak. But I think the pandemics, we are now thinking of scaling, of developing another document that will take into account any kind of emergency on the health system, so that we are not disrupted whenever such a situation happens, as has been the case at the beginning of the pandemics in the country. And the last aspect is on communication. We've learned very much about communication, because the role of social media, the way people react to the information that they received, and our communication department has been working on new tools and new approaches to get to the population, and for full inclusion of social media as a communication channel, and that is being capitalized. Something that was very important that we learned from the COVID pandemics, and we think it will be very helpful in coming days for the program. Thank you.
Thank you very much, Cameroon. Tanzania, anything to add?
Okay, thank you very much. Yeah, in Tanzania, of course, we implemented a lot of strategies, and what it is important lesson. The very important thing is to reassure the community, because even in our country, our president reassured the community that we must learn how to live with COVID-19. So the community, together with health promotion, health education by staff from health sector. So education, by educating the community on how the disease can be contracted, how can it be prevented, and with the implementation of all health measures to prevent the disease, it is very important to reassure the community. And also, we conducted a lot of coordination meetings. We had the subcommittees, for example, logistic team. We had a barrier team, IPC team, surveillance team, laboratory team. All these were working together to make sure that any case, if will be diagnosed or will be reported somewhere. So the team work together to make sure that no more cases can be diagnosed, that can be infected or by or to ensure that the cases cannot spread in this area. So good coordination by good coordination, including political leaders from private sectors, coordination by private sector. So even in the local made PPEs, for example, here in Mwanza, there was one hospital prepared some PPEs. So this is a lesson that we can't depend on external donors only. Even in our country, we can manufacture some items to ensure that the COVID-19 is prevented well in our country. So that is how the strategies for health promotion, coordination meetings, and the reassurance of the community is very important to make sure that this COVID-19 is prevented in our country. Thank you.
Thank you, Tanzania.
Can I add?
Yes, please do add.
I would like to add to what Dr. Calvin mentioned earlier about communication. I think what is very critical is actually the strategic and risk communication. We were quite, we did it quite well in that sense because we had, the principle was it must be factual, it must be transparent. So there were daily press briefings done for the last 5 months at 2 p.m. and 5 p.m. by the same person at the same time and with a consistent message. I think that actually gained a lot of public trust in the situation, and we are able to sort of handle it well. And we used extensive social media and also mass media and a lot of campaign and social public awareness was done. So I think if moving forward, a very clear strategic and risk communication plan is important in any crisis, be it pandemic or a disaster.
Thank you so much, Fazila, for that further clarification. There is a comment from Vish from Sydney. What about information challenges such as lack of interoperability, lack of one source of truth of data? I think Fazila just sort of touched on that.
Well, Chilunga, if I can have the,
fault lines and cracks and information and the technology architectures exposed due to COVID-19.
Yeah, if I may be,
please
if
do.
I may begin, and thank you to the other panelists. In the Philippines, we had to make sure that the data and information required by the policymakers are actually quality data, they're relevant, they are timely, And so we really had to work very hard on this. We had to work with the WHO, and they provided us assistance with the health information system application. We had to work with third-party developers for our analytics. We had to work with local governments. And so we decided to organize ourselves a coordinating committee that look at all the digital tools so that we can integrate them, so that there's nothing that would be a duplication, that's a waste of resources. And when we had to get feedback, because we had to improve the integration of these systems, and we have to make sure that everything goes through a process. So if an application is proposed, for example, it goes through a process to the end user. For example, that's the Ministry of Health or our Department of Health, as we call it. And so it's going to be validated, and then it's endorsed to another agency, the Department of Information and Communications Technology, and then the National Privacy Commission looks at the privacy issues so that we have an application before it's deployed to the public. It's going to be useful. And for the analytics, we're able to do forecasting. We're able to show daily information together with the daily pressers like just Malaysia. And it's available on our website, and we are all over the place in social media. And this is very important. Chilunga. Thank you. Over.
Thank you so much. Any other comments on that particular issue from Africa? Information technology and the COVID pandemic? Cameroon,
Yeah, thank you.
Tanzania, yes.
Okay, thank you. Here from Tanzania. In Tanzania, on the information technology, we have integrated the disease surveillance and response. This is sorry. Hello.
Yes, go on.
Yes.
I'm not quite sure what's going on here. Why are we having this? Somebody's sharing a screen they should not be sharing. Thank you.
Okay, thank you.
Please, Cameron.
Yes. Yeah, we have an IDSR system. This is web-based, which is integrated into district health information management system in Tanzania. This is a tool that we do report on a weekly basis. So during the COVID-19, also we developed a tool that is an electronic tool, that is an Excel sheet to accommodate all data pertaining to the COVID-19. But mainly we use integrated disease surveillance and response tool, which is a web-based integrated into district health management system. That's what we use in Tanzania.
Thank you. Any comments from Cameroon before I open it up to the floor?
Yes, in Cameroon, we had the DHIS-based system for management that was designed, but at lower level, we're using an Excel-based tool to collect all information. And it was further aggregated at regional, then central level, and introduced in the database that was created for COVID. So we received the support of WHO, and we've not really faced challenges in COVID-19 data management. But with regard to EPI, we got some challenges, because most of the actors who were involved in the fight against COVID, that resulted in additional workload for health personnel. Most of these actors were EPI, were those who were working with EPI. So the system, based on the experience of API in the surveillance, because API carries out surveillance activities. So, and data management. So our data managers were mostly those were used for data management of COVID. And also our surveillance officers were mostly involved in the management of COVID management activities in the field. So this caused like a drop in the completeness and timeliness of reports of immunization reports in our API system. And just 2 weeks ago, we held our monitoring and evaluation meeting for the program. And what came out is that the workload was responsible for this, the drop in completeness and timeliness of reports that were observed in the system. So I can say this is the principal challenge we got with COVID, talking about data management. Thanks.
Thank you. There's a note from Vina Pearl Bongolan. Can I ask you to ask your question, please, because I can't make out what exactly what you're asking.
Well, thank you, Madam Chair. But I don't think, I mean, we're very active, and Dr. De Castro is here now. We're modelers in the Philippines, and I don't think we can avoid using several data sources. No matter what the data source, you could expect delays in the updates, mistakes in measurements and reporting, not to assign the blame or any malintent in anyone's part, but I think that's just the best way to get to a better estimate. And so we look at the databases from WHO, the DOH, of course, in the Philippines. And then, especially in the early parts of this epidemic, we were getting tweets. You know, I mean, and we were using high schoolers to collect data from tweets. Some local government units actually went to Twitter, and they were just giving data information from tweets. And so we used all those. And yeah, I don't think it's any advantage to have only one data repository. And honestly, I mean, with all the mistakes we would expect. Thank you.
Thank you, Pearl. Any response from the panelists or anybody else in the audience?
Okay, I can understand Vina where she's coming from. In fact, I remembered many years ago we tried to data mine Twitter, and we wanted to find out if we can actually predict dengue outbreaks. And we were able to be successful on that front. And in fact, when you establish data standards and you design information system, data sources can be helpful, except that for this COVID-19, we had to be organized. We had to, you have to realize that we have to have certain indicators that will tell us if we are flattening the curve, we are actually identifying outbreaks, we are successfully doing contact tracing. And so we had to work with Google, Apple with their exposure notification. And so while there are so many data sources out there using different platforms, we decided to integrate them and make sure that we get the most out of them. And very, very cautiously and carefully, we did analytics so that policymakers will be guided, especially that this data and information were badly needed for imposing different categories of quarantine in many areas in the country. Thank you. Over.
Thank you.
Thank you very much. Vina, does that answer your question? Happy with that response?
Well, I am much aware of what Dr. Tayag mentioned. No, there is another comment from Dr. De Castro, whom I work with. Epidemiology modeling must not be unilateral from one group only. Well, I do agree, because Dr. De Castro and I form one group, and there are actually several doing epidemiology studies, and I think that's overall healthier than having anything centralized. No? Because listening to only one source, has problems, I think. Thank
Vina,
you.
Vina, I can understand you. We welcome the other analysis of groups. While we have this faster with DOSC and Ateneo, we also welcome reports from UP and other individuals with Dr. De Castro have analyzed data. You're most welcome to share it with us. And personally, I also do my own estimations, modeling. And if we share this and understand the context for which they were actually done or created, then we can have a better understanding of the COVID-19 situation and response to it. Thank you, Vina, for those insights.
Thank you, Dr. Tayag.
Thank you. Let's move along then. There's a question in the chat box about contact tracing from Vish from Sydney. Were contact tracing applications useful? Maybe Vish, you can open up and ask your own question.
Okay, for that question on contact tracing, for the Philippines, we had manual contact tracing and digital contact tracing. We have yet to launch the Google Apple exposure notification, and we're going to monitor the results. For our initial undertaking with manual contact tracing which was developed by a third party, an industry developed apps, we initially hit a wall because of privacy issues, and so we had to take a step back and work with the third-party providers so that we can address the privacy issues, and then we are going to launch it again. So meanwhile, contact tracing traditionally, when tracers are sent or deployed to households and do interviews and detect these cases or contacts, that's what's going on, and we hope that technology can support it so that it will be easier for contact tracing to be accomplished. Thank you.
Sorry, Vish, yeah, very quickly. The reason for my question is I'm in Sydney, Australia. What happened here was the government spent, I don't know how many millions, several millions of dollars on the contact tracing application, and asked everyone to download. There's a big campaign with television and all that. At the end, we found out that after a few weeks, the number of people identified with contact tracing was one. Only one. So we were all very unhappy. The public money has been spent in an application which was not designed properly. The Bluetooth was not working properly. That's why I want to know what the experience of other countries.
Oh,
thank you. Thank you for sharing that experience.
Yeah, thank you, Sitaraman, for your observation. That's why we did not rush into it. We want to make sure that everything was in order, and we were getting reports from other countries so that before we decided to actually deploy these applications, that there would be validation, vetting, so that we do not lose sight of any inadequacies or inefficiencies that can come out of these applications. And we're not going to spend that much. Thank you.
Thank you. Yes.
Sorry, can I add? Yeah, Vish,
sure.
Thanks for your question, Vish. Same thing in Malaysia. Our main app is the My Sejahtera app, but it is more of a community empowerment app where there's a lot of multi-function, and some of it includes it's mandatory for check-ins at premises. So indirectly, it can do contact tracing. And but there is a study now being done. How many cases have we picked up using this app? But of course, a lot of contact tracing is also done manually. And the Ministry of Science and Technology is also having a beta version using Bluetooth, but it is still it's not used widely. And some of the states have their own app for check-ins, to check in into premises, and also to manage their own risk assessment and also health assessment. So basically a lot of things is happening. But with the new one that Apple and Google has launched, we are still studying it, and let's see how we are going to use that. But it is still in a very early stage. Yeah.
Thank you, Doctor.
Thank you. Any other comments on applications with contact tracing from the audience or from the panelists? Any interesting experiences with use of applications for contact tracing from the panelists or from the audience?
I think it would have been good if we had Singapore online. I think Singapore, I think they have Bluetooth-based contact tracing,
okay.
But I don't have much info on that.
Okay.
Well, we are close to actually deploying our exposure notification based on a Bluetooth with Google and Apple. We are now having tests before its publication. Then it's and we want to make sure that every prerequisite, we're not rushing, of course. We want to make sure that we're doing this right before we actually deploy it. And as for the manual tracing, there's another application for that, and it's our local governments that are actually encouraging the public to download the apps, and it needs a critical number of individuals to actually download it, and there is active participation of local government when these apps are finally deployed. And we have to monitor, get feedback on privacy issues, its effectiveness. This is not something that we deploy and have it to chance that it's going to provide results. So we really have to monitor its progress and even compare it to traditional means of doing contact tracing, because at the end of the day, you want to make sure that you get information that can actually result in minimizing the spread of the infection. Thank you. Over.
Exactly. Thank you so much. Let's move a bit away from the applications and go back to something I think which every country has been riddled with. And this is a question from Alvin Marcelo, saying social media has been both boon and bane. How did you handle social media, especially fake news? We'll start with the panelists and then go into the general contributors.
I'll take that question.
Yeah, please.
Actually, fake news management was as bad as managing the COVID. It was spreading as fast as the virus, you know. So we had two approaches. One was a Ministry of Health and one was at the national approach. So at Ministry of Health, what we did, we formed a close WhatsApp group with social media practitioners. These are practitioners who are influencers or influencer of in a major social media platform. So this is part of our rumor surveillance by our crisis center. So these practitioners, they receive the alerts from their followers on either rumors or unverified news, and it is immediately investigated and clarified by MOH, and the feedback is given. So that is one from the Ministry of Health. But at the national level, we have the Multimedia Commission, Multimedia Communication and Multimedia Commission, where they launch an official Telegram news portal to curb the spread of the fake news. So anyone in the public can just go in and check whether the news that they have received, to verify whether it's real or not. So that is also very helpful. So daily there is fake news, and these two type of measures that Malaysia is doing has been very helpful. Over.
Thank you, Fazila. I'd like the same experience in the Philippines, wherein there's a dedicated website so that information regarding COVID-19 will help individuals to actually practice acceptable behaviors for non-pharmaceutical measures, that they have to stay home, wear their masks when in public, do physical distancing, and promote hand washing, for example. And of course, there was another purpose for doing that is to minimize stigmatization and discrimination. Because Fasila in the country, I don't know if in Malaysia or in Tanzania or Cameroon, those with COVID-19 are unfairly discriminated and stigmatized. In fact, people stay away from them, from households. In fact, some of our frontliners would be ejected out of their abodes, and it was very disconcerting to us, and that's why we had to change their mindsets, the understanding of the COVID-19, and this was really the purpose for making sure that in social media we are actually well posted, so that to give the proper information and not to lose on this fake news. And even in treatments, they're giving fake news on treatments, and we had to warn the public of treatments that may actually be harmful. And Fasila, that happened to us, and I don't know if Malaysia, Tanzania, or Cameroon had the same situation.
Oh yes, we had the same situation, Eric, in stigmatization, in fake news. So over and over again, we have to keep on reminding and educating our public, and also in the press briefings daily, the Director General of Health will also keep on giving constant message on this matter. It was very challenging in managing fake news.
In Cameroon,
any experiences from go on, Cameroon.
We were challenged with fake news, but as a strategy from at the early stages of the pandemics, we had a very offensive communication by the Minister of Public Health, assisted by the director in charge of her promotion. So every day we had updates on the situation of COVID, reminders on what to do in order to prevent and to stop the spread of the virus. And also on social media, we had tweets from the minister directly on tweets of the minister. You also had the Facebook page of the ministry, where we could have updates and advices on where to go, what to do in order to avoid, and in case you have symptoms, where to go. And also the government made sure that all concerning COVID was free of charge, and those who were tested positive, they were not kept in the community. There were places, we have houses, social houses that were built by the government, and these houses were equipped, and we could quarantine most of those who were at the beginning tested positive, and they were receiving everything they needed there, including care. And this avoided having stigmatization in the community. So those coming out of there, first of all, it was you couldn't know who went there and who did not. And when they are cured and tested negative, they go back in their communities. And their family usually considered them as survivors, because At the beginning, the communication of COVID was something very dangerous, lethal, and so people were really afraid of the outcome of the infection. But many of them were cured and went back home safely. We didn't face much of stigmatization in the communities because of this disposition the government had taken to test people, have them quarantined, treat them, and test them back to make sure they are healed, cured, before they go back into their communities. So this is what happened. We also had medias, because private media contributed also in fighting rumors and fake news on in the communication sphere. So they were having discussions with the communication department of the ministry to give them the right information that will be communicated. So all of them were communicating on COVID. All of them were showing the WHO spot on the prevention measures to adopt in order to stop the spread of the COVID. So although there were fake news, although there were people in social media saying funny things on vaccination against COVID, poison, or the various treatment like preparing garlic decoction and all the like, but there was an intense communication on the good information that prevented people from following all these fake news that was spread in social media. Thanks.
Thank you, Cameroon. Any comments from Tanzania or anybody from the audience?
Thank you very much from Tanzania. We had the same issues for example, fake news, even rumors in the community. So health personnel visited the area where rumors came out, and then he clarified the issues to the community. And even they found that there's a person with typical features with the COVID-19. So proper measures were taken to ensure that he is taken he or she has taken a sample for laboratory testing, for laboratory testing. So clarification to the community, even in WhatsApp groups, there were fake news. So the government did well with this fake news and the rumors in the community. So clarification, health educations to the community on how the disease is contracted, can spread, and some of the symptoms were well elaborated to the audience or the public. So then they understood. That's why they understood and the reporting rate, or when the community became understood about the COVID-19, so the rumors or fake news declined. So that is, so it was not different from other countries as they explained, like in Cameroon and the other countries. Thank you.
Thank you. Any comments from the general audience before I move on? I don't see, oh, wait a bit. Okay. There's a comment from Vina in the chat. It seems to me contact tracing is useful only at the start of an epidemic. It seems to have limited use once the disease goes into the community transmission. And then another question is, do you evaluate the linkage between contact tracing and testing? Okay, I'm reading the ones that are related. How do you make efforts to identify people with no symptoms of COVID-19, which is currently an issue of increasing cases of COVID? Any of those questions, can the panelists address them very quickly because we are running out of time now?
Yes, concerning those who have no symptom, how do we address? The minister have declared we are now in the community phase of the disease, and what we are doing is just mass testing. So we are testing people in the various communities. So tests have been sent in all districts in the country, And people are encouraged to go and test, and there are community health workers helping in this, going in communities and encouraging people to go for their test. And although we privilege those who present with some symptoms of the disease or signs of the disease, but we extend the testing to others who feel like in fact, we encourage the other members of the community to go and test. And this massive screening is also part of the strategy of finding who is infected and give them proper management and prevent the spread of the virus to other members in the community. So this is what is ongoing now in Cameroon.
Thank you.
Yeah, for Malaysia, in terms of contact tracing, we have a few approaches. We do mass screening for the red areas. The red areas meaning cases more than 40. But we also have the targeted approach testing where we test the vulnerable and high-risk group, some localities, or when there's a cluster outbreak. But our active case detection, contact tracing is ongoing. And we are doing also the SARI and AeHIN, the influenza-like illness surveillance. We also do pre-op surveillance. All pre-op cases undergo testing. That's how we can identify, but the numbers are very small. And also new hire and return to work also do testing. So it's a mix of random testing, targeted testing, and mass screening.
Yeah, and to add to what Fasila has already mentioned, we're looking at pooled testing so that we can reduce costs further. Thank you, over.
Thank you. I think the only thing I haven't heard addressed is the linkage between contact tracing and testing itself.
Yes.
Yeah.
What we do is when someone is tested positive, we find out all the persons he has been in contact with, in close contact with, and this is feeding the list that community health workers use for contact tracing. So whenever a positive case is detected, when the test is performed and the person is positive, now we identify there are a lot of personnel in charge of identifying those he has been in close contact with for the past days. And these now are traced by community health workers, and a test is proposed so that we find whether they have been infected or not. And those who are infected will be taken in charge, and still their contact will be traced also. So that is a strategy that is implemented in the fight against COVID in our country.
Thank you, Calvin. The next question is from Atika Adayas. I'm not quite sure where he or she is calling from. How do you make efforts to identify people with no symptoms of COVID-19, which is currently an issue of increasing cases of COVID? Anybody wish to tackle that one? I have no symptoms. How do you manage? How do you make efforts to identify people with no symptoms of COVID-19, which is currently an issue of increasing cases of COVID? In other words, how do you identify those who are symptomless?
Oh, yeah, we do contact tracing, and so those who are vulnerable are actually tested, and we have our priorities of vulnerable population. Our frontliners are regularly tested, so this already include the asymptomatics, and those who actually are returning residents, Filipinos who are coming back from other countries. There's a routine testing, and when we opened the businesses, because we had to ease up restrictions on travel and work, then there have been procedures for identifying asymptomatics through testing. We have procedures, and we have standards on how to make these tests and how to interpret them. Thank you, over.
Thank you. The last two are just comments. from Vina, one from Vina saying, an educated and confident population is the best defense to fake news, I think. The fact that a lot of people in the Philippines believe unbelievable things tells me our people are scared. Well scared, stupid, what? Well scared, stupid with the situation, I'm not sure. Again, the stigma could be cured with education and information. I think the point she's making is that we need to educate our people so that they're not taken in by all these things. Sitaraman from...
Yeah, Chiluga, this doesn't go away easily, and you really have to look at the root causes of this. So you have different options how to address them, and
Yes.
Repeated messages that that improves their confidence and trust can actually have an impact on how they see things. Now they're scared, and then they become confident. That's what you want to happen, that they will not be discriminated, that they will have good behaviors on making sure that they stay home, wear their masks, do physical distancing, and do hand washing. And when they do this, then we have accomplished our goal. Over.
Yes, over. Thank you. The last comment from Vish is government publicity programs are generally badly managed, outdated, and so there's no trust in them. People turn to social media. People turn to social media. I think that's the end of his comment. I think that's just a comment. I don't know if, I think, yes, they can be generally badly managed, but I think some programs have been quite productive in terms of publicity in some of the countries. Any comments on that from the panel?
Well, Chilunga, the public will always have a different perspective of what government does. But once they are actually involved, then they'll understand how government works. And this is not for the interest of any person, but this is to make sure that everyone stays safe, they're protected against COVID-19, and that the government is there to give all the support that the citizens needed. The trust is something that we have to work on it together, because government should also trust citizens, when the public should also trust government. And it's going to be difficult, but there are ways how to do this, and working together is always the best approach. Thank you. Over.
Thank you.
I really adhere to what Enrique just said. We definitely need to work with civil society organization. At least the population needs to have an eye on what we're doing, because most of the time the doubt is due to ignorance, and people are prone to believe that what they don't fully understand is not safe for them. So at times we come with solutions, but when the population has not been associated in deciding, they look at it, they don't really trust what we say. So we've been working on this, having civil society organization involved, and this civil society organization helped us most during this period in sensitizing the communities. And it seems they are more understood, they are trusted by communities. Whenever they endorse the message from the government, it passes better. So it's also a lesson learned that we should reinforce this collaboration with civil society organization. Let them know what we do, how we decide, why we take decisions for the population. This can help enforce the trust in what we are doing, and better acceptation of the solution and strategies that the government is giving by the population.
Well, thank you, Calvin. And we're running low on time, so I'll just ask the panel to ask you to answer very, very quickly. Just tell me, just one thing. I'm looking at what has happened in your context. What could your country have done differently, or what would you do differently to minimize the impact of the COVID-19 pandemic on health services? One thing that you've observed is, say, if we could have done this, we would have had a better result in terms of health service delivery. Just one thing, and I'll start with Enrique.
Oh,
Something
if
you
we
could have
had,
done differently.
Very early travel restriction, then because that's what the information we have for the COVID-19 spread, then we could have maintained containment rather than go into mitigation. Thank you. Over.
Excellent. Fazila?
In fact, I wanted to say the same thing. I wish we had the. I think we could have improved.
I'm sorry, Fazila.
We could have done it better if we had the border control, you know. But anyway, yeah, it's just looking back, you know, and now it's.
Yeah. Anything else?
I was thinking also in managing the health workforce. I think we could have been better coordinated if it was the mobilization of volunteers and other health stakeholders is done at a local or regional level, and not everything is centrally controlled. I think that will be better.
A bit of decentralization.
Yeah.
Thank you. Calvin?
Yeah, for me, I think in addition with what to what they just said, I think we would have had a preparedness plan for such situations. We would have reacted better, especially in the various other aspects, because COVID itself was a problem, but its impact on other activities of the health system was also a problem. And having a good preparedness plan that defines all the coordination and deployment strategies would have helped us better react to the pandemics. Thanks.
Thank you. Tanzania, one thing you could have done differently?
Yes, thank you. Yeah, one thing is to have an adequate preparations and a proper allocation of resources, for example, fancy personnel and the other issues. We do, through these adequate preparations, like Mr. Tonga said, a preparedness plan, it's very important and it is very crucial. So adequate preparations, it is very important. Yeah, thank you.
So much. Well, I think we've come to the end of, I can see a question here. Oh no, it was just a second. I think we've come to the end of our discussion, and it remains for me just to thank the panelists. You really have educated us. We thank you so much, and I thank the audience for their very searching questions. And I hope that at least in part, those questions have been answered. But more importantly, I hope we all have learned something, something that we can use, something that it will be helpful to us. And I really love this learning from Asia to Africa and Africa to Asia. I really do hope that we'll have more interesting joint webinars on things that matter for us. I'd like to thank Dr. Mjajati. I'm sorry I took over your moderation, but we had to start on time. And I know that it's very challenging sometimes in our part of the world to join a meeting. Sometimes you just keep trying and you just don't join, and it takes a bit of time. So there are those technical issues still our end of the globe. Thank you very much to Catherine Miyawala and for Christine from the AeHIN for organizing the webinar for us. They put in a lot of effort. I know there was a lot of to and fro between Christine from AeHIN and Catherine Miyawala from BLN. Thank you very much for your effort, and thank you for the speakers. We know it is tough. The time, the time differences were a little bit challenging for the secretariats, but at least we got this one done. And I thank Alvin Marcelo also for actually being agreeable to this joint collaboration and for cross-borders learning. And in fact, he proposed it in one of our meetings. So we thank you also for that, Alvin. Thank you for your broad-mindedness and your willingness to advance the learning across continents. With that, I just want to say thank you to the audience as well. We've been in for almost 1.5 hours, and most of you have stuck it out. I know we lost a few, but yeah, 1.5 hours is a lot of time to ask of any technical person. So thank you all. Where it is evening, afternoon, have a good afternoon. Enjoy the rest of the day. For those of us for whom it's still morning, have a good day. God bless you all. Be kept safe, and I hope we'll see you again. Bye-bye.
Bye-bye. Thank you very much.
Thank you very much, Calvin and Amos. Thank you.
Bye.
Thank you. Bye, Fazila. Thank you. And thank you.
Thank you.
Thank you. Bye.
Thank you, Sharice and Christine. Thank you.
Thanks, everyone. Bye.
Bye.
Bye-bye. Have a good evening. Thank you very much, Dr. Puta. Dr. Mdajati, thank you very much for making time to join us.